There we go. Go ahead, please.
Okay, awesome. Thanks so much. And I did want to just quickly thank Kelly for the invitation to participate in this panel. And to throw it way back to 2023, I want to thank Sarah Connolly. I'm not sure if she's on here, but she's a gem nurse at Sinai in Toronto. And she actually connected me with PGLO and with Kelly first going off, which has been really invaluable for me. As mentioned, I'm in Newfoundland and Labrador. I am the first and only gem nurse here. And I'll give you the history of how this came to be in Newfoundland and kind of where we stand right now. But I did just want to take time as well to quickly thank anyone who's ever responded to my emails in the network or taken the time to chat with me as I kind of got myself up and running here. It's certainly been something I'm very grateful for. So I accepted my first permanent full-time position as a nurse practitioner back in May 2023. This newfangled role called GEM, again, the first one in Newfoundland, so very steep learning curve here. Essentially, I was the only qualified applicant. It was one of the few permanent jobs available at the time, and despite not knowing what GEM was, I kind of jumped into it. And 2 years later, here we are. So um, I was advised, in that interview that I'd have a really unique opportunity to help shape and develop this role. And of course, that really meant I would be doing all of that work myself. So probably not dissimilar to some of the folks in other smaller, newer gem areas. Next slide. So this is just to let everybody know, here I am at the very tip of Newfoundland here, the very tip of Canada. And that's just our little provincial bird, the puffin, you may be familiar with. So, we're the youngest province in Canada. We joined Canada in 1949. And in a lot of ways, we're still very much behind the times, especially when it comes to our healthcare system. We're very geographically challenged, so we encompass Labrador as well, which is quite remote and rural. And of course, we're separated, physically from the rest of Canada by a body of water. So um, a lot of these things lead in together, but it's also worth noting that we have the largest proportion of seniors in Canada, sitting at about 24.6% in 2023. Next slide, please. So just to give a little context, I've learned a lot about Ontario's geriatric regions, I guess. Just this is what it looks like here in Newfoundland. It's quite a young specialty still. So our first practitioner started working here in 2013. She was a care of the elderly trained physician. She was joined by our first geriatrician in 2016. So really just 9 years ago. We've now got 4 geriatricians servicing the province and numerous care of the elderly physicians. And as you can see, kind of services are heavily concentrated in this eastern urban or the northeast Avalon where I live. And that's due in part to this being our capital city. And for places such as Labrador, we're doing our best, but right now that's a traveling clinic twice a year that we offer there. Um, The division of geriatric medicine within Newfoundland Labrador Health Services is fairly recent as well, just about 5 years old. And we are working on how to grow things at home. So we do offer care of the elderly training in St. John's, and they are working on creating a rural college program for geriatrics based out of our Memorial University of Newfoundland. And just a fun fact, Dr. Kenneth Rockwood, the creator of the clinical frailty scale, he is a Newfoundlander actually. So I'd like to point that out. Next slide. So I've commented on how bleak healthcare can be in Newfoundland, but what really brought everything to light was this health accord that our government engaged in. So it's an extremely intensive review of our system, and then the outcome was a 10-year implementation plan to address areas that are struggling. And the aging population, as well as hospital services, were two key areas that were pointed out that they wanted to tackle first in this plan. Newfoundland actually has, the worst life expectancy in Canada, up to 2 years less than some other provinces. And we're really spending the most per capita, but seeing the worst value for that investment. So it's been realized, thankfully, that, we need to change the way things have been historically delivered. So this is where the senior friendly emergency departments or the GEM program kind of came from. That's where the funding directly came from my position and the other positions that I'll talk about soon. We've also seen the implementation of and the creation of acute care of the elderly units from this health accord, as well as a strategic health network for older adults, which is a provincial network with a director and a clinical physician lead to try to coordinate the services. So the goal being that if a senior enters any emergency department or any hospital in the province, we are working towards standardizing that care to make sure that everyone is receiving an equitable and appropriate care in the senior population. Next slide, please. Thanks. So, as mentioned, it's just me here currently. I do service two of our largest hospitals in the city, two of the emergency departments. So St. Clair's Mercy Hospital, as well as the Health Science Center. Both are in St. John's. It's about a 10-minute drive in between each one. So, not necessarily unreasonable, but it is Newfoundland. We do have terrible winters and there's of course hospital parking to contend with. So it's not intended to stay this way forever, but starting off, I guess the funding really only existed for this position. So prior to my position coming to fruition, there was a geriatric emergency department working group started within the emergency program. And that was started in about January of 2022. So it's a group of physicians and managers and other key stakeholders in the emergency departments trying to make improvements, knowing that the health accord had recommended different changes. There's lots of policies been made, and we are working on applying for bronze accreditation with GITA now. But the other driving force behind the geriatric emergency management role in Newfoundland has been our geriatric group of physicians, or geriatric medicine group of physicians, I should say. So they really are my biggest supporters. I, speak with them probably on a daily basis on times, and we we certainly chat back and forth, whether it's about a case in particular or if it's about, bigger, more systemic issues that we're noticing and we need to address. So they certainly always have my back there. You can go to the next slide. So the indications for referral that we've come up with, Dr. Pridham is one of our physicians here, and she had completed her training in Ottawa and had some familiarity with GEM there. So it's kind of where we got some of our ideas from. But where I'm looking at focusing on patients who are over 65 in the emergency department, but they are coming here from their own home, not from any kind of assisted living. Now, a lot of that is just due to my capacity. And we're intending that they're being discharged back home as well, or in some cases being assessed for ALC from the emergency department. And we're looking at one or more of the following issues. There's also undiagnosed cognitive impairment included right now in the referral, but something kind of we're deliberating about removing just because that's obviously not necessarily a great time to be diagnosing in the emergency department. And it's, getting me into a tangle a lot of times, and something that should be deferred to an outpatient setting. And we do have fairly good access with our geriatric clinic. So I do have exclusion criteria. So those living in long-term care on the basis that their frailty is not likely reversible. Those who are expected to be admitted to acute care, or those who present with just social work issues. So they just need home care supports. They can just see social work. We have a social worker full-time in each of our emergency departments. Next slide. So this is just a brief little snapshot I've done up. In 2023, I guess just for context about the size of our emergency department, 2023, 10,000 unique visits between the two sites were for seniors over the age of 65. My 275 referrals, that's been since I started. I started actually seeing patients in November 2023. So it's been about 19 months now. I did complete like a 6-month care of the elderly-esque training period. It wasn't necessarily formalized, but I was lucky enough to be able to have that opportunity with geriatric medicine locally. I'm curious though if other clinicians, and you can pop it in the chat, but would you also agree that most of the clinical frailty scale or frailty level of patients you see, would that also coincide with like a moderate frailty, or are you able to get a little bit more uphill, a little bit more preventative in your approach in GEM. That's something that's been interesting to me is I feel like a lot of times the ship has sailed on things we could be reversing when I'm involved in patients. And the other piece I'd like you to think about and comment on is this statistic here. So 17% of the patients that I've assessed then go on to be admitted to hospital for an acute reason. I'm curious if that's also happening in your other areas. Because that's been a surprise for me, actually. It's, almost 1 in 5 of my patients actually end up admitted to hospital. Next slide. So a quick day in the life. I generally start at St. Clair's Mercy Hospital. It's in kind of downtown St. John's. And a lot of that is just the fact that I do have my own dedicated office here. I don't have that at my other site. I will admit sometimes I have a bad habit of checking in my laptop at home, looking at the referrals in the morning to see what's on the go for the day and where should I go first. After I do receive a referral, I'm spending a little bit of time, as I'm sure we all do, researching the patient. We have 4 different databases that I might have to look into at this point in time. We're working on getting the Epic system here next year. And then I join this morning huddle most days with the Home First team. So that's kind of a rapid response interdisciplinary team that we're so lucky to have in St. John's. And it includes a nurse practitioner, physio, OT, social work, and a rehab assistant who can really facilitate lower intensity rehab at home. So most often pubic rami type fractures or non-operable fractures, but they do have a broader catchment than that. Really closely liaise with our emerge social workers and sometimes, feel like I'm blended into that role in some days for sure. I go back and forth between sites as necessary, but there is, an understanding that if it's late in the day, I'm not going to dive into something at the other site until the following day type thing. So patients are often held for me. And then also that frequent contact with the geriatric medicine team. Next slide. So challenges, one of the most frustrating things that's been very eye-opening to be involved in the back end of healthcare is we've had an 8-month delay of operationalizing funding for our physio and our OT. So we were told we had the money last spring, took 8 months to get these positions posted, and they're still not officially hired with a start date. So very, very slow process for a service that's desperately needed. There's certainly a lack of awareness of GEM and what I'm meant to be doing here, given I'm the only one here. So I've been trying to tackle that education piece among emerge staff, among nursing students, but certainly something in hindsight, wish I had spent a little bit more time on in the beginning. Covering 2 sites that are not that close together, I don't recommend. It's certainly not sustainable, but I'm just kind of hanging on here until we get our funding, hopefully this coming budget cycle for my counterpart that will take over one other site. And then I really struggle with a lack of pathways. So having the ability to navigate a patient once I've assessed them and done a CGA in the emerge, I might identify they need restorative care. We don't actually have that in Newfoundland yet. We don't have acute care of the elderly units in St. John's yet. We also did start screening with the clinical frailty scale in emerge, but it's just new. We started it in March with our emergency room physicians and certainly a varied uptake on that at the moment. So trying to work on that the best way we can. And then identifying appropriate referrals, I think might be something that everybody's struggling with. But if anyone has any suggestions, I'm here. So please reach out. Next slide, please. So in progress, as I've alluded to, I'm very excited about this physio and OT, I always joke that the GEM team is me, myself, and I, but thankfully I'll have extenders and support coming hopefully in the next few weeks to months. I am working on a document that would hopefully be used as an interdisciplinary assessment. We don't have it fully flushed out yet, but that's partly due to wanting the physio and the OT who accept these roles to have an input on that. But ideally, it would be something, if the OT sees the patient first and, we're all gathering a lot of the same information, they can note it down. Then it's documented for the 3 of us to be able to save some time in our charting going forward. And shout out to Nicole Gallagher with Northeast Specialized Geriatric Services. She gratefully shared some of their documents with me. So we're kind of modeling it off more of this tick box based approach to the CGA. Next slide. And so successes, we do have education ongoing, as I mentioned, with nursing students, nurse practitioner students, medical students, and I think I'm out of time here probably, but the acute care senior friendly manager, I just wanted to highlight that's part of our strategic health networks direction. So this is one particular manager. She's not responsible for any specific unit, but she's responsible for implementing health accord senior friendly strategies in our hospital. So I think that's going to be really great moving forward. And you can flick to the next slide, but it's more for reference for people. This is the tool that we developed, the form that we developed, I should say, for our physicians who are not necessarily comfortable or familiar with the clinical frailty scale. We did get permission for use from Dalhousie and Singapore group for this algorithm on the back, but trying to help make it as easy as possible to assess that frailty scale, because the intent is as we grow our pathways, restorative care and the ACE unit will be opening within the next month in St. John's. So we want the frailty scale to be, the gatekeeper, maybe not the best word, but like what's going to trigger those pathways. So thank you.
Thanks, Jen. I feel particularly honored that the entire province of Newfoundland and Labrador is without you for the moment as you are presenting. It feels very, very special. So thank you for your presentation. We'll go to Lisa now. Lisa, if you want to start to load up your presentation.
Yes, will do.
And let us know if you need any help.
Okay, I think my screen is shared.
It's just coming up. And there it is. And it's not quite in full view yet. So we'll yep, there it is. Go ahead.
So hi, thank you for having me. So I'll be presenting about our geriatric multidisciplinary team in the emergency department at St. Mary's Hospital, where we're composed of a social worker, physiotherapist, occupational therapist, geriatrician, and myself, the nurse clinician, directly in the emergency department. I am a nurse clinician, so I'll be presenting this within the scope of my practice. And just a quick thank you to the St. Mary's Hospital Foundation, who is currently funding our team. It wouldn't have been possible without them. It's plan of the presentation. So we'll just talk about why have a geriatric multidisciplinary team in the emergency department. I'll present our team, show two brief cases of how we do successful discharges and safe care transitions, and then we'll look at some statistics. So why have a multidisciplinary team in the emergency department? So 20 to 40% of emergency department visits are patients greater than 65 years of age or older. This is a high proportion of emergency department visits relative to their percentage of the population, and it's estimated to continue to grow. In Quebec, 45% of all hospital stays are used by individuals aged 65 plus, and they only make up about 14% of the population. We know that there's an increased complexity with older adults. They present with atypical symptoms on top of cognitive impairments, multiple comorbidities, and then the functional and social impairments. Oftentimes, this is even met with unmet care needs in the community, which further complicates their disposition. And of course, geriatrics is a team sport, so it's just a way too complex for one single clinician to manage. You need a team of different expertise for that holistic approach. And we know that there's risks associated with prolonged emergency department stays, medication errors, mixed doses, not being mobilized. The emergency department is just not conducive for the older adults, especially with MNCD. And this is it all increases the risk of delirium and is associated with increased mortality and increased length of stay in the hospital. So that leads me to presenting our amazing team in the emergency department at St. Mary's Hospital, obviously in Montreal, Quebec. I don't know if I mentioned that. So from the left to right, we actually have a medical student in this picture. And it's nice, we often work with medical students and residences, and they get to learn and see how we function as a multidisciplinary team. You have myself, the nurse clinician, our occupational therapist, physio, our geriatrician. We actually work with 4 different geriatricians, and they rotate throughout the week. And then, of course, last but not least, our social worker. So goals of our geriatric multidisciplinary team. So we use a multidisciplinary approach to address the complex needs of older adults and their families presenting to the emergency department. We optimize hospital admissions and promptly find alternative solutions for those not in need of an admission and ensure safe care transitions of an older adult after any emergency department visit. And this just means ensuring discharges are safely planned and coordinated to decrease returns to the emergency department related to that initial visit. So let's speak a little bit about how our team functions. So as you can see in the diagram, of course, we have the patient and family at the center of our care, who we very most of the time, almost all the time, the patient and family are implicated in our plan of care. So each one of us have our own expertise and perspectives to address the complex needs of each older adult. And this multidisciplinary approach enables us to do a more thorough evaluation of all domains, medical, cognitive, functional, psychosocial aspects directly in the emergency department. So we have our geriatrician who obviously leads the medical evaluation. We'll do the medical workup for common geriatric syndromes that we see, such as delirium, polypharmacy, falls. Myself, the nurse clinician, will do the nursing assessments, assess the nursing care needs in the hospital, as well if the patient is discharged. And a large part of my role is also case management, where I'm kind of managing the cases that we see. And I also screen the whole emergency department for geriatric syndromes to see if there's a patient that will benefit from our services. Our physiotherapy, who assesses mobility and function, our occupational therapy therapist that assesses functional ability and safety in performing their ADLs, as well as our social worker for the psychosocial factors that we see in the emergency. So as you can see, we have unique roles. They do at times overlap. Um, uh, but so we're a multidisciplinary team, but we do act as well as an interdisciplinary team in the sense that we don't just work in parallel. It's more of a collaborative approach. So through the approach, we explore alternatives to hospitalizations, improve the quality of care provided to the patient through targeted, timely, and interventions, and we enhance emergency department flow and efficacy by reducing admissions and identifying the right care pathways. So I'll bring you along a typical day for the geriatric multidisciplinary team. So I start the day and I start very early around 7:15 a.m. And I start by screening the whole emergency department for patients greater than or equal to 75 years of age or with positive PRISMA scale of greater than 4 with geriatric syndromes, as well as the patients that have already been consulted to our multidisciplinary team. I'll do a chart review, collect data. I'll see if there's any caregivers at bedside because we like to implicate them as early as possible. And then I'll look over all the consults with the physiotherapy. Sometimes the physiotherapist will have a consult that's not necessarily consulted to the multidisciplinary team, and we'll kind of see if there's another member of the team that needs to be involved for this patient. We try to do this as early as possible. Then myself and the physiotherapist attend and participate in the emergency department sign over. So we're there sitting in the meeting when the emergency staff gives sign over to the day doctor, and we'll pay special attention to those consulted to our team and other patients that we hear are in for a geriatric syndrome or geriatric needs. At 8:30, we have our morning rounds. So that's the geriatric multidisciplinary team rounds. And this is where I present the cases. So I present the patients that were consulted to, and I also mention other patients that are in the emergency for a geriatric syndrome, and see which team members need to be implicated for that patient to have the best emergency stay as possible and see if they could be discharged. So then from there, we develop the care plans of each patient and we divide and conquer. And like I said before, we don't all as a group see each patient as a collective. We go where we're most pertinent and we divide the work um, wherever we're relevant, even though we discuss every single case as a team. Then at 9 o'clock, we start getting to work. So each professional intervenes according to the reason for the consultation. At this time, patients are going for testing. We're doing our assessments, evaluations. We're communicating with all the external stakeholders, doing our databases, etc. At 11:30, we meet again and we have a second meeting. And this is where we reevaluate patients and our action plan. The nice thing about it is because we start so early at 11:30, we usually already know which patient could be discharged or admitted. If they need to be admitted, what else needs to be done? I often will communicate with the charge nurse on our geriatric inpatient unit and just give her a report and tell her the plan of our admission because we want to try to get them out of the emergency department as soon as possible for them to go to the geriatric unit. And if a patient needs to be discharged, what needs to be put in place for this discharge to be as safe and as comprehensive as possible. And then for the rest of the day, we're tackling new consults. The kind of day restarts with we get a new consult, we have to divide, and we kind of do the process over again. So I'm just going to share two patient cases that we've seen in the emergency department and see how we're able to do a safe discharge. So let's look at Miss G. Miss G was an 87-year-old female with a known diagnosis of major neurocognitive disorder. She was residing in a private independent senior residence, and we were consulted because she came in with left leg pain and inability to mobilize. Some background information, the daughter expressed that she's been falling more frequently. She noticed the increased difficulty with her ADLs and IADLs, including hygiene and cooking. And the daughter was expressing concerns over this progressive loss in autonomy and her ability to cope in a independent senior residence. She also had a Doppler done, and it showed that she had a left leg thrombus, and that was obviously the reason for the left leg pain. So this case required a lot of us. So the geriatrician did the fall workup. There was some polypharmacy that was probably contributing to her falls, prescribed pain control, consulted the specialty services such as hematology because of her past medical history. The usual anticoagulation for her thrombus was what wouldn't have been appropriate for her. Physio and occupational therapy did the functional and mobility assessment, also assessing why she may be falling, and assessed her ability to do her ADLs. Myself, the nurse, I did the nursing assessment, gathered collateral information from the family, and determined nursing care needs if she would have been discharged. And the social worker got involved as well because we wanted to see if the patient had a home care file. The daughter wasn't completely sure about this. It's something that they thought about in the past. So she wasn't sure if that was a file that was still open. So in the end, we decided she could be discharged home, but there was a few things that we needed to put in place. So we requested for home care services to do a OT home assessment to see if there could be some adaptations we put into her home for fall prevention, as well as anything in the home that may be contributing to falls. We asked for hygiene care support because the daughter and the patient herself admitted this has been more hard for her. We discussed community resources with the daughter and the patient for groceries and medical transport, as well as gave them lifeline information. And we also asked home care to follow up on this in the community. And then we asked for nursing services to be organized for her fragment injections that could be done at home. So a nurse was going to go into the home every day and give her fragment injections. Physiotherapy provided her with a walker because it was determined that because of her gait instability, a walker was now needed. And we arranged medical follow-up. So she had an outpatient hematology follow-up arranged, and a summary of everything we did in emergency was sent to her GP for continuity of care. So in the end, she was discharged safely home and returned to her autonomous residence. And I think the important thing to understand is this was all done in just a few hours. By 3 p.m. that day, she was discharged home. We also have a few patients that we see like Mr. D, and this is a patient that is not able to go home. So an 88-year-old male with known Parkinson's disease who lives in an independent seniors residence, he was receiving home care services about 3 times a day. So he was consulted to us because he had a fall, which resulted in a left humerus fracture and a right patellar fracture. So he was now in a left arm sling and a right leg Zimmer brace, further impacting his mobility because he had Parkinson's disease. So OT and PT assessed him right away in the morning, and it was determined that he was unsafe to go home. He had significant mobility limitations now because of his fractures, and he wasn't able to participate in his ADLs. Other than that, he was medically stable and he didn't really require an acute care setting. So what we did is we applied for convalescence right away in the emergency department. It got accepted to the next day, and he was discharged 2 days after being admitted to the convalescence. So even though he needed to be admitted, we significantly reduced his length of stay in the acute care setting. And just some regional context, we do have this program in Quebec called Planification précoce et congé de congé. In English, it means early and joint discharge planning. It was developed by the Quebec's Ministry of Health and Social Services. So what it is it emphasizes early discharge planning to reduce hospital length of stay and avoid unnecessary institutionalization from the moment the patient enters the emergency department. So this is our way of integrating the principles of Quebec's PPCC initiative by initiating interdisciplinary discharge planning from the moment the patient arrives in the hospital and addressing those functional, medical, social needs collaboratively. So some statistics 1 year post the implementation of the geriatric multidisciplinary team. So these are comparing 2023, where when the team did not exist, and 2024, now that the team does exist. Another thing to know that in 2024, we're actually seeing more patients, and these are probably patients that were missed in 2023 because now because of the triaging and screening, we're identifying those high-risk patients. Um, in 2023 as well, it was the stats were only it was only the geriatrician seeing the patients, whereas now in 2024, 80% of the patients are being seen by the geriatrician and 20% were seen by one or more member of the multidisciplinary team. So we've seen a decrease in 10.5 hours in the length of stay in the emergency department, an increase of 15% in discharges from the emergency department. So patients are being stabilized faster, a decrease of 28% in admissions. And we've also seen a decrease of 2% in return visits to the emergency department within 30 days of St. Mary's. So even though this percentage, the last one, seems a bit smaller, what we are seeing is a trend. So even though we're discharging more patients from the emergency department, they aren't coming back more than they were in 2023. Because one of the concerns was, oh, but if we're discharging people, are we discharging them prematurely? But we're not seeing that with our statistics. And it's also because of these results that our CIUS, in Quebec we call it the CIUS, and that's basically our regional kind of healthcare system in our geographic area. They've actually now decided to start funding us, so we're really happy about that. Challenges and successes. So a challenge is the increasing number of older adults in the emergency department. It could sometimes render a very high volume of patients to see. And we do work Monday to Friday from 7 to 3. And our inpatient geriatric unit is relatively small. It's about 23-ish beds. Risks of iatrogenic complications in the emergency department. Sometimes we have a very narrow, small window before a patient ends up becoming delirious. And then home care service reductions or limited availability. We rely a lot on those external services in order to get the patient home safely. So when there's a decrease in those services, it's not very helpful. Successes. So obviously delivering a positive patient-centered emergency department experience for the older adult. We were able to enable evidence-based best practice nursing care into the emergency department. So we actually created modules for the bedside nurses that is now mandatory to complete. And this is kind of like gold standard nursing care to do at the bedside. It's called in Quebec, we call it approche adaptée à personnes âgées. I think it's in English, I believe the term is adapted approaches to the older adults. And obviously, we've achieved safe discharges with reduced hospital admissions. Another milestone ahead for us is that we just sent in our application for a geriatric friendly emergency department. I believe Jen spoke about it briefly in her presentation, and it's the Geriatric Emergency Department Accreditation Program. We're applying for a level 3 bronze. And this is the level 3 bronze is an emergency department with a strong foundational commitment to improving care for older adults. So our accreditation is pending approval, and if it's approved, we'd actually be the very first hospital in Montreal, Quebec, to have this type of accreditation. And other fun stuff, we have been featured in the media. So we were on the White Coat Black Art podcast with Dr. Brian Goldman. We've been shown in La Presse, which is our local newspaper article. And then our social worker was just recently highlighted on Global News. Thank you so much for having me.
Thank you so much, Lisa. And you're giving us lots to think about in terms of not only data to collect, but ways to talk about yourself. I love the linkage to media. Uh, yeah, excellent. For
Thank you
both
so
of
much.
you, thank you. Sorry for that. I didn't mean to cut you off. Thank you both. And I just also want to just highlight the chat for both Lisa and Jen. Take a look in the chat. Jen, people are answering your question about hospitalization. I think one concept that resonates with people is admission with a plan, and that's something that's facilitated by Jen. Lisa, you just referenced that length of stay is kind of much shorter when people are admitted after having seen your team. And then you're getting some questions, Lisa, about Prisma. So if you might, or tools that you're using for screening in the ED, just as Brittany sets up, if you don't mind, just maybe responding in the chat to let
Sure.
people know what you're doing, that'd be super. We're going
Sounds
to turn
great.
it over to you now, Brittany. Thank you again, Lisa and Jen, and we'll turn it over to you.
I guess it would help if I unmuted myself.
We can hear you fine now, and we can see your full screen.
Perfect. Thank you so much. Thank you so much for inviting me. I'm really thrilled to be here. I love the interdisciplinary working that comes with working in geriatric emergency medicine. I'm going to be presenting a slightly different angle, both coming from a physician and, as you will see, coming from a province that doesn't have geriatric emergency management nurses, but also having worked with them previously throughout my training, both in Ontario and briefly in British Columbia. So I'm just going to start off by kind of laying the land a little bit. We've heard a lot today from some fantastic programs that both Jen and Lisa are doing, and I know many of you will be joining from Ontario, where there's a lot of great work going on. But this is a bit more of a national picture of what geriatric emergency medicine nurses look like across the country. So there's lots of red, as you can see. Red are the provinces where, to my knowledge, and kind of based on my review from our geriatric committee, there's no established nursing in emergency departments at all. Um, Yellow provinces are those, so including like British Columbia, where there's intermittent pockets of really good practice. I know Island Health has some programs up and running, Fraser Valley as well, and some integrated management teams in Vancouver, but also many big areas with fairly significant populations that don't have access to geriatric nurses in their ED. Manitoba, Saskatchewan, sad to say, where I'm calling from, where my home is, we're not there yet, but I'm going to talk a little bit more about that. And then obviously Ontario, you guys are well aware of Quebec. We just heard from Lisa. There's some really fantastic work also going on in Quebec City, as well as in Sherbrooke, where I believe, well, my colleague Adrienne Brousseau works as a geriatric physician there, and they actually have silver accreditation through GITA, which is fantastic. Um, and then obviously moving over to the Maritimes, we heard from Jen about some of their challenges. Newfoundland has a program, and I understand that there's a second GEM nurse in the works, potentially, Jen, is what I've heard from Dr. Furlong. But most of the other maritime provinces don't have any geriatric emergency coverage in their EDs. And I think what we've heard more than anything, and what I've learned as I've worked in geriatric emergency medicine, is just the amount of variability, both in models and in success, and that it's not always about the model, but the models and integration is a key part of the success. So when I talk about the different models, we know of both registered nurses as well as nurse practitioners who work as geriatric nurses in our emergency departments. And probably the biggest thing is whether that individual is operating alone, kind of never alone truly, but alone in terms of their title, and maybe some of the supports they have, versus being an integrated member of a dedicated team, like we heard from Lisa, which I think we can all agree we would aspire to be both a part of and to create. And I know I'm sitting here amongst the converts, I will say, but there's so much work ahead in terms of geriatric emergency nursing and care in emergency departments across Canada. I think we're really fortunate to be working in a team environment, but we're also very fortunate to have the ability to really impact the day-to-day care of older adults. I think that, you know, I hate to use the term sentinel events because I actually don't think that when older people come to the emergency department, that's the sentinel event. I think the sentinel events have been probably missed, and now they're here with kind of reaching that crisis point. But it's an opportunity to intervene that didn't exist 15 years ago. geriatric nursing didn't exist. Geriatric emergency physicians didn't exist. And so I think this is a huge testament to just the progress that's been made across the country, and specifically in certain areas. So, why is somebody here from a province talking to you about geriatric nursing who doesn't actually have a geriatric nurse? And I asked Kelly the same thing. She was very kind and let me continue to come. But I kind of wanted to share some of my experiences, and in hopes that by sharing my experiences, we can also help to garner a better understanding of many of the challenges that exist outside of the places that you all live and work. So we know geriatric nursing works. We've heard about all the benefits, reduced stays, decreased revisits, decreased admissions, improved functional outcomes. And as of recent, we actually have fairly good data published out of the US, albeit, but still good data to support that there are healthcare system savings through the use of gem nursing. Um, but we also know that it's a pretty significant uphill battle. So, speaking from a Saskatchewan point of view specifically, I moved to Saskatchewan. I moved back home to Saskatchewan in 2019. Um, I was the only person that had any kind of clinical work or involvement in geriatrics, full stop. So, what I mean by that is there was not a single geriatrician working clinically in our province at that time. Um, Within a couple of years, even less than that, of me starting and beginning to work and try and develop networks and establish the importance of care of older adults in our EDs, we had COVID. And that put a big halter on a number of the projects I was working on, specifically some work regarding delirium. We came out of COVID, things kind of slowly, actually were quite slow for about 6 months to a year. And now we're hit with a crushing capacity challenges, like many of you will be. Hallway medicine is unfortunately commonplace throughout all of our departments. And in addition to that, we have a significant physician and nursing shortage. We have dearth of temporary travel nurses. We have a really high nurse turnover and difficulty retaining nurses in our departments. So it seems that, and many of the conversations I had and continue to have, although they are evolving slightly, is that people are struggling to keep their heads afloat, and that they didn't have the capacity to engage in further programming and further implementation of services. And I really attribute that to a lack of understanding of the added benefit of geriatric nursing and geriatric programs in our emergency departments. So, what do we do? Well, it seemed that every time I brought up geriatric nurses in our departments or even enhancing care of older adults specifically, I was met with roadblocks. And so I began to kind of try to work around some of those roadblocks by doing a number of things. First and foremost was I started to build relationships. I think you'll all appreciate the importance of relationships and really establishing those from the ground up. We were successful provincially in recruiting some geriatricians. So we now have 7 geriatricians in the province, not 7 full-time, but 7 total, probably the equivalent of about 4 to 5 full-time geriatricians working in our province of 1.2 million people. In case you're wondering, the Canadian Geriatric Society recommends 1.25 geriatricians per roughly 10,000 of populace, which would put our desired intake around 100 geriatricians, actually over 100. So we're very short of geriatricians, and that was a bit of a problem because we didn't really have programs or opportunities or didn't know what to do if we were successful in setting up a geriatric nursing program. But we now have 7, 4 in Saskatoon, 3 in Regina, who's our other major center here. And we are working with, and there are conversations going on right now about the establishment of geriatric nurses. In addition, I've been working with and linking in with our allied health services in our emergency departments. So we've begun to establish increased coverage with physiotherapy, occupational therapy, and we now have an ED-based pharmacist who I regularly discuss complex polypharmacy patients with. And so essentially what I'm trying to do, and don't tell my health authority, please, is that I'm trying to build services and models that really fit around having a geriatric team and a geriatric nurse specifically in our ED so that having that person is going to become the easy answer. They're going to become the quarterback for this team that we're already building without them really knowing that that's the team that we're building. Beyond that, we've also begun some clinical work. So I've recently developed and launched a provincial pathway for management of delirium in our emergency departments. We're building geriatric carts like many of you might have. And we're talking now with a recent ED remodel of our spaces about having dedicated spaces for older adults with more appropriate environmental adaptations and equipment for them. So those are some of the things that we're doing, and we're really trying to work towards geriatric friendly care, or at least have streams of work that are going towards that. So some of the challenges that we've undergone in Saskatchewan, and I know upon discussing this with colleagues from across the country and also hearing the presentations from Jen and Lisa, I think a lot of these challenges are echoed across the country. So one of the big challenges was prioritization. When everybody seems to be drowning, who do you save? Who do you throw the life ring to? And for a very long time, it wasn't older adults. I think more and more, though, we're beginning to see that older adults are recognized as core populations, and that hopefully we'll begin to see that GEM nurses are essential to their care in the departments, in emergency departments. Funding has also been a challenge. In Saskatchewan, I don't know if this is a common problem. I'd love to hear if you guys are aware of who your funding comes from and what departments. So for example, when we're talking about having a geriatric nurse in our department, is it owned? That's not the appropriate way, but is it funded by the internal medicine in the Department of Geriatrics? Is it owned and funded by internal medicine? And what are the links to these services, and how do we ensure that it's responsive to all of these departments as we engage in these services? Recruitment and retention has been a challenge, as I mentioned, with nursing across the board. And so it's kind of like feels like robbing Peter to pay Paul sometimes when it comes to recruiting nurses from other areas of care. There is a dependence upon other services, so having adequate geriatricians and adequate clinics that we can refer patients to as outpatients, or having geriatricians who actually have admitting privileges, which they don't have in our hospitals presently. And I know there's many, many places across Canada who lack access to subspecialty services, including geriatricians. How do these services fit within our existing framework? So in Saskatchewan, I saw somebody asking in the chat there about access to home care coordinators in the ED. Well, we actually have something called a QRP coordinator who's a home care coordinator based in our emergency departments. The problem is nobody really knows what they do in terms of they don't have a defined job function. They've been in their service for a long time. They do some really great work, but it's very variable depending on who's actually in that position. They have no specific geriatrics training. They have no clinical training. And so how do we kind of integrate somebody else when there's pockets of work that are already ongoing and overlapping? I think this has been highlighted, but sometimes working in geriatrics and having an interest in older adults, you feel like you become the answer to all things older adults. And I'm constantly questioned by my colleagues and provide input into their cases. But I certainly think that geriatric nurses, as Jen highlighted, I think have difficulties with appropriate referral pathways and recognition of appropriate patients to refer. And then the last thing is called the je ne sais quoi effect of geriatric nursing, in that we don't really know why it works. We don't know what that single golden thing is that works, but we know that it works. And sometimes when you talk to high-level leaders, when you talk to policy, when we talk to our Ministry of Health, they want to know what is the effective thing? And it's challenging to say, well, we don't have a single isolated thing, but this program works. These people work. This job is important. The QR code I should have mentioned on the top right, there is a link to our position statement on care of older adults in the emergency departments that we wrote on behalf of the Canadian Association of Emergency Physicians. And it does specifically cite interdisciplinary working in geriatric nurses as one of the key recommendations. And then we know it works, but how do we get, senior level policy workers, senior level leaders, to know that it works? And this is one of the things that I think about a lot. I'm so glad to hear about Lisa's program and the data and evidence that they are collecting to demonstrate the effectiveness of it. And I think that it's something that we don't do very well in geriatric emergency medicine in general. I do know it's growing, and I know there's a speaker next, so I should probably not talk about this because they're going to have a lot to say about research in this area. But I would urge us all to consider how we collect data, what data we collect, and how we can use that to support the evolution and development of these programs, both where we work, but also across Canada. And I think there also needs to be a focus on high impact changes. Sometimes with older adults, it's so complex, and we know that there's so many things that we could be doing in our departments. I just, I get overwhelmed sometimes when I'm asked what we could do different because it literally feels like everything. But really, as leaders in this area, focusing on high impact changes, we know there's 10 things that we could be doing better, but sometimes the leaders don't want to hear that. They want to hear about the most effective two to get us running and moving out of the gates, and then we can start doing the rest. But if I can tell somebody, a physician, a nurse, a care aide, a healthcare leader, that we are going to make their jobs easier, and these are the two ways that we are going to do that, and in the meantime, we're going to improve the care of older adults, then I think that's a really effective way to sell these programs. And sometimes it feels like that's what we're doing, is selling. And what are the opportunities? We've heard a ton about this, but these are some of the opportunities that I see moving forward with geriatric services in our emergency departments. So one is creative collaboration for service improvement. I actually was recently involved and gave a talk to rural Alberta physicians and providers about geriatric care in EDs. And working in Saskatchewan, it really often gets me thinking about how we can do better in our non-typical service delivery models. So, for example, I encourage our rural physicians to reach out to community pharmacists to help them engage in medication reviews of complex patients or patients with polypharmacy. In Saskatchewan, we have an evolving and growing and really, I think, quite strong community paramedicine program who are working in the community, specifically have programs targeted towards older adults. And so I think there's a growing amount of services, and we need to get better about knowing what these are and collaborating with them. I talked about enhanced data collection to support the work of GEM nurses nationally and to promote ongoing growth of these programs, and that we need to have better and further integration of both patient and caregiver experiences into our measured outcomes. We often talk about length of stay, readmission, not attending the ED unexpectedly, etc. And those are all super duper important, and I think important for that selling thing. But we also know that this is really important to older adults and their caregivers and loved ones. And I don't think we're very good at collecting this data or demonstrating this. I'd love to see, and Kelly, maybe you can do this, the development of a national coalition for geriatric nursing. In Ontario, you guys have such an established, awesome program. I think it'd be such a great starting point to try to, and maybe you're already doing this, and I'm sorry if I'm speaking out of hand, but to try to have more of a national coalition where we can use it to really leverage advocacy work, promote what work you guys are doing, and lead a voice for a call of GEM nursing across Canada. And finally, I just really want to close with one more thought, and that is what keeps me going, what I love about working in geriatrics in the ED, and that is the people and the teams that we work within. It's, in my mind, one of the best worlds to be in. I get to do emergency medicine. I get to see acute, clinically unwell patients. I see complexity. I have opportunity to work with these patients, to learn about them, and gain respect about finding what works and what their goals are for really, in my mind, the people who deserve it most. We have a very, very active geriatric emergency medicine committee, as Kelly referred to. We very much welcome non-physician members into our committee, and in fact would love to have some more. So if you are interested in joining our committee where we engage in education and policy work and advocacy for older adults in the ED, shoot me an email. Be more than happy to welcome you, to introduce you to our network across Canada, and hopefully continue to support the work you guys are doing and grow the same work in Saskatchewan.
Thank you very much. You've kind of opened our eyes to the not only the challenges but the opportunities, but also that there are others out there. I think sometimes we feel really alone. We're often in single positions. Maybe we're the only one in the emergency department or in the province in some cases. And just to know that there are other like-minded colleagues across the country that care very much about the issues facing older adults in the emergency department. It kind of gives us somewhere to go with our thinking that takes us a little bit outside of our everyday. What a fabulous panel. I hope you are all feeling as I do about these amazing champions. If we can just have a show of hands and congratulations, everybody I'm really touched by what an individual can do in a province and an organization, on a team. And I'm just so impressed with all of your work. And thank you so much for taking time out. The other thing I wanted to highlight for you is just I could really hear an important theme about the impact of policy, enabling policy in some of our provinces. Certainly, and we could hear in Jen's example and Lisa's example, there's a policy lever that it was supporting the work that has transpired. So that's really something important for us to watch for. And I know that we care a lot about that from a PJLO perspective. So thank you so much. Please note the celebrations in the chat for you, reflecting on your wonderful contributions today. And do check out the website for other links to the CBC article. And I also, if I'm not wrong, Brittany, I thought I saw a LinkedIn post that you're a co-editor of a book related to geriatric emergency management. So do watch for all of that activity in this space.